طيب السلام عليكم. My name is Ibrahim Amar, and today inshallah I'll be discussing the skin lectures. As you all might know, these are actually three different lectures, but they're all embedded into a single lecture. I'll upload each of the three parts separately, and then you can watch them all, and inshallah you can comprehend the lecture. ترى it's not a very difficult lecture, to be honest. I'll agree إنه it might need some kind of memorization, especially in the management, but you also have to understand that the management is based solely on the pathophysiology of the disease itself. So if you're going to have a disease that is related مثلا to bacterial infection, you're obviously going to have antibiotics in the management. If the disease is primarily مثلا due to an immune response, you're going to have corticosteroids. So it primarily relates to the pathophysiology of the disease itself. أعرف إنه كثيرين might think that I talk too fast. I'll try my best إنه I slow down وإن شاء الله you can comprehend the lecture. So let's start with the common skin disorders number 1. Before we go into the lecture, I really believe that there are some kind of definitions and there are some kind of background information that we should learn about before we go into the lecture itself. My handwriting isn't the best in the world, but I'll read everything that is written. Inshallah, and you can understand what's written. We have different types of skin lesions, and each of which have a different definition. فأول شيء, the first one is the macule. So what's a macule? A macule is a flat, colored, well-circumscribed lesion that is less than 1 centimeter. The most important thing that you have to know is that a macule is flat and it's less than 1 centimeter. The second one is a patch. What's a patch? A patch is just like a macule. It's flat, it's colored, it's well circumscribed. However, it's greater than 1 centimeter. For both of these, you have to link them together into a single category. One is less than 1 centimeter, the other is larger than 1 centimeter. The second one is a papule and a plaque. So what's the difference between both of which? A papule is an elevated, solid less than 1 centimeter. Why is it important to know that it's solid? Because there are some lesions that contain fluid. So you have to know that a papule is actually an elevated, but that elevation underlines a solid lesion, not a fluid containing lesion. For a plaque, it's also a papule, but it's greater than 1 centimeter, right? So just like a macule and a patch, here we have a papule and a plaque, but a papule is less than 1 centimeter, a plaque is greater than 1 centimeter. So let's move on. What's a vesicle and what's a bulla? A vesicle is a fluid containing blister, right? So here it comes important that this one is actually made up of fluid. It's not made up of solid, and it's less than 1 centimeter. Whereas a bulla is basically the same as a vesicle, but it's greater than 1 centimeter. Right? So both of these, you also have to group them together into a single category. But then what's a pustule? As the name might suggest, so you have pustule, you have the letters PUS, pus. So it's a pus containing vesicle, right? As the name might indicate. What's a scale, right? When you see a skin lesion and they tell you that this is actually a scale, okay, what's a scale? A scale is actually flagging off of the stratum corneum. Do you know the skin layers? I hope you do, Yani, and I know that you actually do. There are different layers in the skin. So we start with the first one, stratum basal, spinosum, granulosum, lucidum, and corneum. I know that you know them. So the scale is actually the flagging off of the stratum corneum, the uppermost layer of the skin. طيب. And what's a crust? A crust is a dry exudate. Like what's an exudate? An exudate is basically, when you have an infection or مثلا you have a lesion on your skin, but then that lesion مثلا produces some kind of pus or مثلا produces this fluid, right? So what is this fluid? The fluid is actually made up of different components, and mainly it is made up of proteins, a lot of proteins. When this exudate actually when this lesion actually pops up, يعني لما تنفجع هذا الexudate كله يطلع. So you kind of have a dry lesion, and this is what we call a crust. But then I think this is, you have to comprehend these very well in order to understand the lecture. And I hope I did a good job in explaining them. But then for the infections, so we have a lot of different infections, and especially when it comes to cutaneous infections. However, there are some kind of infections that are most prevalent, and those include impetigo, erysipelas, and cellulitis. And when you think of skin infection, put in mind Staphylococcus aureus and strep pyogenes. These are really the king and the queen of the cutaneous lesions. So always put them on the top of your differential. For the impetigo, it's caused by S. aureus and strep pyogenes, right? And strep pyogenes also has another name for it, and it's known as group A streptococcus. So whenever you see both, each of which, you shouldn't get confused. It has both, both names are used interchangeably for it. So always, don't get confused. For the impetigo, there are basically two types of impetigo. There is the bullous and there is the non-bullous impetigo. The bullous impetigo, as the name might suggest, it's made up of bullae, right? Whereas the non-bullous, non-bullae. For the Staph aureus, I always think of the Staph aureus as this very dangerous microorganism. So when you think of Staph aureus, always think that it can cause both bullous and non-bullous impetigo, whereas strep pyogenes only causes the non-bullous impetigo. But then there's the erysipelas, and we will discuss the differences between each of which as we go throughout the lecture, but this is just to show you which organism causes which. Erysipelas could also be caused by strep pyogenes and Staph aureus. However, it's most commonly caused by strep pyogenes. For cellulitis, it is caused by both Staph aureus and strep pyogenes. But then also you have to know what are the signs of inflammation. So whenever you have an infection, you're going to have signs of inflammation. And these signs of inflammation are really self-explanatory. It's not rocket science. So there is redness, heat, swelling, pain, and loss of function. So let's go through each of them separately. Why would you have, when you have inflammation, when you have an infection, what is going to happen is that you're going to see these white blood cells marginating to the site of infection. So why are you going to have redness? It is because the blood vessels are going to dilate. Why would they dilate? The blood vessels are going to dilate so as to allow the white blood cells to pass onto the site of infection. Right? So this is for redness. Why are you going to have heat? Because, well, as the blood vessels dilate, you're going to have more blood flow, so you're going to have more heat. Why are you going to have swelling? Well, as the blood vessels dilate, once again, you're going to have plasma, you're going to have exudate, you're going to have white blood cells, all of them moving into the site of infection. So you're going to see some swelling. Why will you see some pain? Well, you're going to see pain because there is a lot of white blood cells, and these white blood cells are going to produce cytokines, and these cytokines might mediate pain. Another reason for why you might see pain is that you're going to see swelling, and this swelling might compress on surrounding structures, and it might cause a lot of pain. Why will you see loss of function? This swelling can be so huge that it can actually compress on the internal organs, it might compress on the skin, and you might see loss of function, right? So self-explanatory, really, no rocket science in here, guys. For the treatment, طبعا there are different treatment modalities when it comes to cutaneous disorders. However, generally, those include incision and drainage, and those are usually the ones that are approached first. But then you might treat it with an antibiotic. And why would you treat it with an antibiotic? Is that, as we've discussed in erysipelas, cellulitis, and impetigo, all of these are actually caused by microorganisms. But then if it's too severe, it might actually require hospitalization. So when you go to the hospital, you might see actually a dermatologist who would actually admit a patient for observation under 24 hours. And this is not something that is unheard of. But then for the antibiotics, One that is mostly used is mupirocin, and this is an antibiotic that is used for methicillin-resistant Staph aureus and gram-positive. I know that I've spent a lot of time explaining all of these, but yani, it's really going to make the lecture really easy. Yani. So this is, as you all might know, is acne vulgaris, and I don't think that anyone needs to actually would see this and would suggest that this is something else. So this is really self-explanatory. For the acne vulgaris, it is a self-limited disorder primarily of teenagers and young adults, and there is a reason why it's most commonly seen in teenagers and young adults, and I'll explain it as we go on. So acne is a disease of pilosebaceous follicles. And what are these? So when you have actually a hair in your skin, in your skin, you're gonna have the hair follicle, right? But then you're gonna have something known as a pilosebaceous follicle, a pilosebaceous gland, and this is primarily made up of the sebaceous glands. And what these actually do is that they make up sebum, right? And sebum is a very important part of the upper skin of your upper skin. So sometimes, due to one reason or another, you might have a lot of keratin. Okay, and when you have a lot of keratin here, it's going to block the site of drainage of the sebaceous gland itself. And the sebaceous gland doesn't know that its drainage is actually blocked. So what it's going to do is that it's going to produce more and more and more and more and more and more sebum. So when you have a lot of sebum, but the drainage is blocked, what's going to happen is that you're going to have this inflated so large that it's going to end up with the acne vulgaris, the acne that we see on the skin itself. Now, why do we see it in teenagers and young adults? It is because these sebaceous glands themselves have actually androgen receptors. And you guys know what androgens are. So in teenagers and young adults, you actually see in males, you see a lot of testosterone. You see a lot in females, you see a lot of estrogen. So what's going to happen is that these sebaceous glands are going to produce more and more and more and more sebum, and thus making this acne much, much more pronounced in young adults, right? So this is why we see it in teenagers and young adults. Let's read what's written here. So there is a retention of hyperkeratosis, as we discussed, a lot of keratin, increased sebum production, Propionibacterium acnes, and inflammation. Now, why do we see this infection? It is because in pathology, whenever you actually have a blockage of a site of drainage, right, whether it's sebaceous glands, whether it's really cholecystitis, whether it's nephrolithiasis, right, kidney stones, whenever you see a block, there is going to be some infection. And the infection that occurs in the skin is known as Propionibacterium acnes. And this is also known as Cutibacterium acnes. It used to be known as Propionibacterium acnes. Now it's known as Cutibacterium acnes. For the sake of the lecture, of course, you would have to memorize Propionibacterium acnes, and then you would also see the inflammation. Acne vulgaris has a lot of different presentations, so it could present as comedones, papules, pustules, nodules, cysts, and scars. Now, the comedones themselves, now this is the first lesion that occurs, could be either a blackhead or a whitehead, and I think we all have heard of that. Now, a blackhead is basically when you have the sebum, this sebum itself, when the site of drainage eventually opens, right, and the sebum is allowed to go outside, what's going to happen is that it's going to contact some air in here. And once it contacts some air, it's eventually going to get oxidized. And this oxidization results in its black color, and thus the name blackhead. Whitehead is because, well, this site of blockage remains blocked. There is no sebum going outside, and thus there is no oxidation, and thus it is known as a whitehead, right? So here you have a closed comedone, white. Here you have an open comedone, and it's black, as you can see, blackhead. For the acne vulgaris, there are different factors that could cause it. You might read them all. Things that are actually self-explanatory and you can read them, I wouldn't actually read them, just for the sake of actually going through the lecture really fast. And the goals in treating acne, I think those are also self-explanatory. It would prevent scarring, You could stop the new lesions from forming, and you would teach the patient what acne is. Now, for the treatment algorithm, um, in a lot of these different squares, you might have noticed that there is actually retinoids. What are retinoids? Retinoids are basically vitamin A derivatives. And these vitamin A derivatives actually help in actually allowing the skin or the keratinization of the skin to go as planned, so as to prevent this blockage. And thus you would use vitamin A derivatives, retinoids, in order to maintain the skin on its natural state as it should be. But then you would use antibiotics as well. And why would you use the antibiotics? You would use them in order to treat the propionibacterium infection that we've discussed earlier. So what is this? Again, this is known as acne rosacea. And when I say acne rosacea, you might ask, okay, so we know that acne vulgaris might occur due to the sebum production and due to the infection that follows. But what is the etiology of this acne rosacea? Now, the etiology really is not understood that much. However, it is thought to be due to increased body temperature. And that is why when we discuss in here the factors that might cause acne rosacea, you're going to see factors that could elevate the body temperature. So rosacea is an acne form disorder of middle-aged and older adults, right? It's characterized by vascular dilation of the central face, including the nose, the cheeks, the eyelids, and the forehead. So you might see here, this lady has actually, the disease is primarily on her middle face, so on the nose, on the cheeks, on the lower eyelid, on the forehead as well. So this is the usual presentation of acne rosacea. The susceptibility is increased to recurrent flushing reactions that might be provoked by various stimuli, including hot or spicy foods, right? So increased body temperature, drinking alcohol, temperature extremes, and emotional reactions. And the earliest one is telangiectasias. What are telangiectasias? Telangiectasias are basically just really dilated blood vessels, right? And when you think about it, when you think about increased body temperature, the increased body temperature is eventually going to result in the increased dilation of the blood vessels, and thus telangiectasias are usually a presenting sign of acne rosacea. Now, the diagnosis is based on flushing. And what is flushing? Flushing is when you have dilation of the blood vessels. You might notice that that patient is actually red in color, and this is known as flushing. It's also known as transient erythema, and eventually you are going to have that patient actually returning back to their normal state. You might also see non-transient erythema, you might see papules and pustules, and telangiectasia. And all of these different factors contribute to the diagnosis of acne rosacea. The treatment of acne rosacea is based on topical antibiotics or benzoyl peroxide, which is also an antibiotic. And this is a chronic disease, right? So it continues for someone for a very long time. So you don't only treat that patient when they present to your clinic. No, you continue the treatment for very long term. So as discussed here, the chronicity of rosacea requires that medical therapy may be continued for long term, not only for the presentation of the illness itself, right? Now, what is this? This is also self-explanatory, and you might see, this lady in here has the lesion around her bra. You might see that this lady in here has a lesion on her outer ear. You might see that this one in here has a lesion that is kind of localized to a specific area, suggesting that he might have worn something in here that might have caused this lesion. This one might be caused by this belt that is here. So you would eventually understand that this might be some kind of allergic, there might be something that is related to allergy that is occurring in here. And this is known as allergic contact dermatitis. And this is a type 4 hypersensitivity reaction. Why is it important to know that it's a type 4? It is because there is also another type of dermatitis known as eczema. And eczema is a type 1 hypersensitivity reaction, and this is the difference between allergic contact dermatitis and eczema, right? So it's from direct skin exposure to a substance. It can be allergic or it can be irritant induced, and an allergen will induce an immune reaction, while an irritant might directly damage the skin itself in allergic contact dermatitis. And this is really self-explanatory. Now, there are different sensitizers that might cause contact dermatitis, and you might treat them all, and you might, in the trigger text, these might all clue you into contact dermatitis. So read them and memorize them, I guess. For allergic contact dermatitis, what you would do, obviously, is that you would avoid the exposure to the offending substance. You would use corticosteroids. Why would you use corticosteroids? You would use it because this is an inflammatory disease, right? So you wouldn't use antibiotics. You wouldn't use, you don't have an infection, you only have an immune response. So you would use corticosteroids. You would also cool the skin. Why? Because you're going to have inflammation undergoing. And we explained earlier that heat was a cardinal sign of inflammation. So you would cool the skin using calamine lotion or aluminum acetate, right? And then what is this? So I think in order to really appreciate the psoriasis that is undergoing here, so this is a different disease, guys, just as do not mix it with the allergic dermatitis. You would notice that there are these lesions, these small lesions, and these scaly small lesions that are silver in color would really clue you into psoriasis, right? Another sign that you would almost only see in psoriasis is that it occurs on the extensor regions. So this is actually the knee, if as you may have noticed. This is also the elbow on the extensor surface, and there is these scaly silver lesion, which might indicate psoriasis. So there are erythematous papules plus plaques plus silver scales, right? And all of these are individualized in cases of psoriasis. Now, this is a chronic disease. It's genetically influenced. It's remitting and relapsing, and it's scaly and inflammatory. What is the etiology of psoriasis? Psoriasis, as here is discussed, it's known, it is really, a lot of people think that this might be relating to an undergoing genetical disease. Someone might be born with an increased susceptibility to developing psoriasis. And it usually, but why do these lesions مثلا, if it's genetically influenced, shouldn't it مثلا occur in as a generalized lesion throughout the entire body? Is that because these lesions tend to occur in sites of trauma? So if the knee is, it's usually a site of trauma, so you might see psoriatic lesions on the knee. The elbow as well, you might see psoriatic lesions on the elbow. So it's a chronic skin disorder. Most of the clinical features of psoriasis arise due to a T cell lymphocyte in the skin reaction. So it's very important to know also this. So psoriasis, there are actually different types. There are a lot of different types of psoriasis. However, here I discussed the most common types. So there is the plaque psoriasis, which is a symmetrical psoriasis, right? So it occurs on both sides of the skin, as we've seen here. This is occurring on both knees, right? It's not localized to a single knee only. And it involves the scalp, the extensor elbows, the knees, and the back as well. The guttate psoriasis, what makes it different from the plaque psoriasis is that these are very small lesions, right? They're kind of drops of water, and they tend to follow strep infections. So when you have someone presenting with a history of strep infection and they're having these really small guttate psoriasis and these small psoriatic papules would have a scaly silver appearance, this would clue you into guttate psoriasis, and these are upper appearance of multiple small psoriatic lesions. For the pustular psoriasis, this is usually one that actually presents, that's relapsing, and it presents with malaise, right? And malaise is really a generalized fatigue that you have in your body. It could be localized, it could be generalized, but the generalized one is the most common, and that is why pustular psoriasis is the most severe form of psoriasis. And then there is the inverse psoriasis, right? When we discussed earlier, we've mentioned that psoriasis actually occurs on the extensor surfaces, so on the knees, on the elbows, but for inverse psoriasis, it's one that actually occurs on the intergenous areas. And triginous areas are kind of the flexor areas, as well as it's areas where the skin, two layers of the skin might meet each other. So cheeks of the butt, the inner surfaces, the flexor surfaces of the elbows, of the knees, those are all intragenous areas, and this would clue you into inverse psoriasis. Psoriasis, the plaque type, could be localized or generalized. The pustular, as we've mentioned earlier, the one that is the most severe, it could be either localized or generalized, but the generalized is the most common, and that is why it's the most severe form. So for psoriasis, it's a circumscribed, it's a thickened lesion, and it presents with plaques and secondary erythema and uh, silvery scales. So these are all silvery scales that you might see in someone presenting with uh, psoriasis. You might see also this secondary erythema that presents on this person, and these are usually circumscribed. And what we mean by circumscribed is that when you have a lesion that is actually going diffusely throughout the skin, that you can't actually even draw a mark or a certain border where you would you see that lesion individually, this is what we call as a diffuse lesion. But really, psoriasis is just a circumscribed lesion that you can draw the border of and understand where it begins and where it ends. So another thing related to psoriasis is that it could present with psoriatic arthritis. And this psoriatic arthritis could either present with it, so dependent psoriatic arthritis presents with the cutaneous involvement. It could present independently. It has a specific appearance on X-ray, and this is what would clue you into that this is actually psoriatic arthritis and not any other type of arthritis. Psoriasis may also present with pitting of the nails as well as crumbling of the nails. So you might see here that this nail is crumbling. It's basically degenerating, or it's breaking down, and this is known as psoriatic crumbling of the nail. Right? So for the treatment of psoriasis, you might use a lot of different treatments. You would use topical emollients, and these are basically moisturizers of the skin. So you have this skin that is very dry. You would need to hydrate the skin, and you would use emollients. You'd use topical steroids, and you would use tar. And tar in Arabic, it's known as al-qatran. And this is very interesting because actually al-qatran has keratolytic and anti-inflammatory effects on the skin. You might also use calcipotriene, and calcipotriene is basically a calcium D analog. And something interesting about calcium is it's a vitamin D analog. And something interesting about vitamin D is that it's actually anti-proliferative, so it might mediate anti-proliferative effects on the skin, and that is why you would use a calcipotriene. And then there is the tazarotene, which is a topical retinoid, and we've already discussed the retinoids, and we've mentioned that there are vitamin A analogs, and these actually maintain the keratin of the skin. And then there's methotrexate and cyclosporine, and those are actually anti-neoplastics. And the reason why you might use anti-neoplastic is that you don't want to have a lot of turnover of cells. And when you don't have a lot of turnover of cells, you're basically going to decrease the propensity of methylene developing these scales that we have seen before. And thus you would use anti-neoplastics. Why would you use immunomodulatory therapy? It is because psoriasis is a disease of T lymphocytes. So you would have to control these T lymphocytes in order to mediate the effects of the disease itself. You'd use ultraviolet light. And this is actually one of the most commonly used modalities in treating psoriasis. And the reason why you would use ultraviolet light is because ultraviolet light has anti-inflammatory effects. And all of these anti-inflammatory effects might lessen the further propagation of psoriasis within the body itself. This is, again, very obvious, and I think most of you have seen this before, and this is known as vitiligo, right? And there are basically different diseases that present with a similar presentation. The first one is vitiligo, and the second one is albinism. And the vitiligo tends to be more localized, whereas albinism tends to be diffused throughout the body. So from head to toe is albinism, whereas vitiligo is more localized to the extremities usually. Now, vitiligo is an acquired skin depigmentation that affects all races, but is far more disfiguring in blacks. The reason why it's more disfiguring in people of color is that in white people, they might not even notice that they have vitiligo unless they're actually exposed to the sun, where they might notice that this area of skin is not actually being tanned as it should. Whereas in the blacks, as soon as someone presents with the illness, they would notice that there is this white lesion that is occurring in their extremities. Now, the precise cause of vitiligo is unknown, but genetic factors appear to play a role in the development of the disease itself. And that is why in 20 to 30% of patients, they may have a family history of the disorder. So this might clue you into that the fact that this might have actually been transmitted from a higher generation in the family. And then the pathogenesis itself is thought to involve an autoimmune process directed against melanocytes. And the melanocytes are basically the cells in the body, or in the skin, I should say, that actually produce melanin. When you don't have melanocytes, you don't have melanin, and then you have these white lesions. So the peak is in the second and the third decades. There is this a common misconception that someone is born with vitiligo. Although people can still be born with the disease, most of the patients actually develop it later. So they develop it in the second and the third decades. The depigmentation has a predilection for the acral areas, and acral areas are basically the peripheral areas and around the body orifices. So the mouth, the eyes, the nose, the anus, all of these might clue you into vitiligo. The course is usually slowly progressive, so it's not very fast, right? And you would imagine that the immune system wouldn't just make the melanocytes disappear in one day, but it's more of a progressive disease. And the diagnosis is based upon the clinical presence of the depigmented patches of the skin, which are characteristic for vitiligo. The repigmentation now in vitiligo, right? You have this white lesions. So one way by which you could treat the illness is that you could مثلا depigment the entire body. So you would make the entire body the same color as the extremity. أو مثلا you would repigment the extremity itself in order to make to make it the same color as it used to be. And the repigmentation includes corticosteroids, calcineurin inhibitors, and those are basically immunomodulatory agents. So they would inhibit the pro-inflammatory cytokines that are produced from the lymphocytes that result in the these lymphocytes, when they kill the melanocytes, they eventually produce these inflammatory cytokines. So calcineurin would inhibit these inflammatory cytokines. But then there is also the ultraviolet light, and we have already discussed, I think, that ultraviolet has anti-inflammatory effects, and it also promotes the melanocyte production. So you would see a lot of melanocyte production after the use of ultraviolet light, resulting in the repigmentation of the skin. You would also use the pseudo-catalase cream. You would also use surgery, which includes mini grafting techniques. And this is primarily approached after years and years of illness, right? You wouldn't approach surgery as a first basis. And this includes the mini grafting of melanocytes within the skin itself. And then the depigmentation therapy with hydroquinone. When you have an involvement of more than 50% of the skin, this means that you basically would never be able to repigment all of that area of the skin once again. So you would depigment it with this agent that is used in here. And it removes basically the color of the skin. So what is this? You might see this and you might wonder that these are actually why is it presenting here with only 2 lesions while here it's presenting diffusely? And the reason is that these are actually basically the mother lesions. And then from these lesions, you would see all of these different lesions arising as well. And these are basically lesions that are oval and they're papulosquamous, right? And do you guys remember what I've said about papules? And papules are basically raised lesions of solid consistency, and they are less than 1 centimeters, right? So always remember that. This mother rash is known as a Herald rash, right? And this is actually might clue you into something that is known as Pityriasis Rosea. And this is an acute, self-limited erythematous skin disease that is characterized by the appearance of slightly inflammatory, oval, as we've mentioned, papulosquamous lesions on the trunk and the proximal areas of the extremities. The eruption commonly begins with a herald or a mother rash, as we've mentioned, a single round or oval, rather sharply demarcated pink or salmon-colored lesion on the chest, neck, or back, right? Again, so really nothing about rocket science in here. You have a single lesion, so the larger one would have probably been the herald rash, and then progressed into different peripheral lesions that you can see in here. And they're 2 to 5 centimeter in diameter. Again, the herald patch, which is the largest one, and it's pink or salmon colored in color. So a few days later, lesions similar in appearance to herald patch appear in the crops on the trunk and proximal areas of the extremities. The eruptions spread centrifugally or from the top down. And what we mean by that is that when you have the herald patch, the progression could either be from the top. You would consider this as the top, the highest lesion, and you would see all of the peripheral lesions going downwards. Whereas when you have a lesion that actually starts in the center and would actually see all of the peripheral lesions developing surrounding it, this would be known as a centrifugal distribution of the peripheral lesions that are seen in Pityriasis rosea. Um, Now, the long axis of the oval lesions tend to be oriented along the lines of cleavage of the skin, like a Christmas tree pattern. And this is actually known as the lesions that are seen after psoriasis, after the herald rash itself, are known as the Christmas lesions. So you might see this as a tree, right? As a Christmas tree. If you would like draw the lines that would clue you into the center of the body, it would eventually result in a Christmas tree, and that is why they are best described as such. The lesions would fade away without any residual scarring, and this is primarily because the lesions are really small, yani, and they're not really elevated from the skin as much as any blisters or other lesions that we might see as we go throughout the lecture. The presence of a herald patch, characteristic morphology and distribution, and the absence of symptoms other than pruritus. So Pityriasis rosea usually only presents with pruritus and not any other symptoms, and thus this would clue you into the diagnosis of this disease specifically. The treatment, you would use topical steroids, you would use antipruritic lotions, apologies. You would use phototherapy, you would use erythromycin, and this is actually an antibiotic. And why you would use erythromycin is that there is actually evidence that suggests that macrolide antibiotics could help control Pityriasis rosea. And the rash usually persists for 2 to 3 months. Right? Now, for impetigo, um, just a second, please. So for impetigo, it's a highly contagious disease. And impetigo, I think we have discussed this on the first slide. Impetigo is a disease that is mostly in children, but it's highly contagious. That is, if the skin actually, if another child would touch the skin of a child infected with the disease, it's most highly likely that they would end up with the infection as well. So it's a highly contagious disease, and it's spread rapidly by direct contact of the skin itself. It is the third most common disease in children, so it often presents in children, and it mostly occurs after dermatitis and genital warts. So these are usually, if you would end up becoming a dermatologist in the future, you would see dermatitis and viral warts, and then the third most common infection would be impetigo in children. The condition is more common in children with atopic dermatitis. And really, whenever you would see a cutaneous involvement due to any reason or another, you would see that this patient would eventually be more susceptible to developing rather different illnesses. Their skin is already compromised. So you would notice that the skin itself would be a suitable environment for microorganisms to grow at, and that is why atopic dermatitis and it tends to make children more susceptible to developing impetigo. The nasal carriage may predispose to the recurrent infection, and that is because the Staphylococcus aureus, the microorganism that mostly causes this disease, it mostly is found in the nerves in your nose. So if you're going to have persistent Staphylococcus aureus in that area, this will predispose you to recurrent infection once and again. So a dermatologist usually might also um, prescribe antibiotics for the nose as well to prevent this recurrent infection. The impetigo might either be a primary infection or secondary to another infection, to another condition, apologies, such as atopic dermatitis. It is classified clinically as impetigo contagiosa or bullous impetigo. And this is the non-bullous and the bullous, as we have discussed earlier as well. For the Impetigo contagiosa, this is the non-bullous one, right? And I think the picture is really self-explanatory. You might see that these are all non-bullous, so you don't have bullae, really. Those are kind of more, um, they're more flat rather than being bullous and raising off the skin itself. And they're honey-crusted as well. And since it's bullous, as we've mentioned earlier, since it's non-bullous, this is most likely, the cause of it is most likely Streptococcus, right? So non-bullous, clue you into Streptococcus. So Impetigo contagiosa is the most common form of impetigo, the non-bullous one. Now, the bullous impetigo, this one, it's very different, as you can see. You would never mix up between the bullous and the non-bullous. And this is primarily because these are really raised lesions, right? They are not as flat as the lesions that we have seen before. Another thing is that you might notice that, okay, but there's this lesion in here. So what is this lesion exactly? This lesion is actually, it was a bullous one, but it eventually erupted and you got the whole fluid inside of it sucked out of it, and thus it resulted in this flat lesion that was primarily a bullous lesion, right? So both of these are actually bullous impetigo. And this is an impetigo pustule. So the bacteria culture will show you most likely Staph aureus. And this is really, it is also self-explanatory that this is a pustule, right? A pustule, we've mentioned before that it's a pus-containing lesion. So this is made up of pus, a lot of pus inside of this lesion, right? Pus, pus, and here you can also see pus. So impetigo pustule, most likely Staph aureus. The impetigo, the blisters are usually replaced by weepy yellow crust, right? And this is primarily due to the dry exudate that is actually seen in the impetigo itself. So whenever you actually, in the target text, right? Whenever you read the word yellow crusted, this على طول should actually clue you into that this is a case of impetigo because this is some kind of a classical presentation for the disease. You might also see mild fever or pain. Again, why you might see fever or pain? Because this is an infection. You might see lymph nodes. Why would you see lymph nodes? If you guys know, Streptococcus pyogenes is actually the cause of the strep throat. And this is, I don't think any of us has never experienced this illness. And so when you have a strep throat, you might have your cervical lymph nodes enlarging. And that's why the usual presentation might also present with enlarged lymph nodes. For the treatment, you might treat it with person or fusidic acid for 7 days, and these are both antibiotics. For the oral antibiotics, for if you have a systemic disease, right? If you have the disease occurring throughout the entire body, you would use oral antibiotics so as to expose the entire body to the antibiotic. So with systemic infections, you would use oral antibiotics, and you would have to treat it very promptly so as to prevent any further infections, for the safety of the community surrounding the child themselves. And also, and this prompt treatment would usually include the proper wound treatment, as well as the application of the antiseptics themselves. Okay, so I think this is okay. Yes, so I think we only have a little bit left until we're done with the first lecture. I'm really sorry that yeah, we're really spending a lot of time, but I hope everything had been clear until now. So for the Staphylococcus scalded skin syndrome, this is caused by Staph aureus, and it is usually due to the production of exfoliative toxins. Why would you see exfoliative toxins? So exfoliative toxins, as the name might suggest or might clue you already, these are toxins that cause the disruption of desmoglein, right? So if you want to review some histology for the skin, as we've discussed earlier, there are different layers of the skin, and there's the stratum basal, which is the most inner layer of the skin, and then there is the stratum spinosum, and then there are the stratum granulosum, there's the stratum lucidum, and there is the uppermost layer, which is the stratum corneum, right? Now, in the stratum spinosum specifically, there are different structures that connect these cells together, and these are known as desmosomes. And one component of desmosomes is desmoglein, right? So desmoglein is actually a component of desmosome. And what happens is that when you have these exfoliative toxins coming into the skin, they would actually inactivate this desmoglein. And so you're going to have these cells detaching from each other, and you're going to have the skin sloughing off, as it's seen in here and also here, right? The disease can appear at any age group, but it would eventually occur in infants, elderly, and the immunocompromised. And these are people who basically still do not have the strong immunity that could fight the Staph aureus. The transmission is usually from one person to another person. There are two exfoliative toxins, so there are A and B toxins. The signs and the symptoms would present with a skin that is burned, right? You would see also other symptoms, malaise, irritability, fever. Again, guys, this is an infection. Nose, mouth, and genitalia might as well be painful due to this scalding of the skin that is actually happening at those areas as well. Now, this is a disease that actually causes body fluid loss and increases susceptibility to secondary infection. And this becomes primarily important because in the management, you would also hydrate the patient as much as you can so that they wouldn't eventually be compromised. And then the susceptibility to secondary infection, we've mentioned already that whenever you have the skin compromised, you're gonna increase the propensity for that skin to be to be actually for a microorganism to actually live on that skin itself and cause a further infection. So that's why there is an increased susceptibility to secondary infection. So the prevention and the treatment, fluid and electrolyte management for the dehydration, antibiotics, anti-staphylococcus specifically, removal of the dead skin. For the desquamation phase, you would use emollients, right? As we've discussed earlier, these are primarily in order to since the skin here is really, really dry, you would eventually use these emollients specifically in the desquamation phase, so as to prevent further desquamation. And then it heals without scarring in 10 to 14 days. So this is primarily of the upper dermis. It wouldn't result in scarring. And you would not use steroids. We might have discussed earlier in the different conditions that steroids would be very important, but in scalded skin syndrome, no steroids. Remember that always. Now for folliculitis, furuncles, and carbuncles, what are these? So these are basically different categories really of the same condition. So for let's go on. I think both of these slides are actually kind of repetitive. So if I explained one of them, the second one would be self-explanatory. So the folliculitis tends to be so let's review a little bit of histology again. So when you have the hair follicle, right? The hair follicle itself might extend into the lower areas of the skin as well as the upper areas of the skin. When you have folliculitis, folliculitis tends to be more at the upper areas. So you have inflammation in this area specifically. Whereas when you have the fruncle itself, the fruncle would present at the entire length, right? So you would see it deep into the dermis, as well as the epidermis, right? Unlike folliculitis that was primarily in the upper epidermis, right? And then you would see carbuncle. What is carbuncle? Carbuncle is basically when you have a lot of different hair follicles, and these hair follicles are all connected to each other, and all of these hair follicles are actually also inflamed, right? So it's kind of more of a fruncle that is connected to the different hair follicles. This is what we would eventually call a carbuncle, right? So again, as we've mentioned, guys, the fruncle, since it's more of the carbuncle, since it's a more continuation of the furuncle, it will be caused by the same organism, right? It's basically just a continuation or a progression of the same disease. So you would see the same microorganism causing the infection itself. Whereas for folliculitis, it might be caused by Staph aureus and Pseudomonas, and these are really, you have to memorize them. There is nothing about understanding in here. So folliculitis, we've mentioned, this is of the upper dermis, and that is why the lesions appear to be smaller. Whereas in the frontals, you have the deep dermis and the epidermis as well. So this is more of a severe, of a severe lesion, right? And this is again a fruncle, and a fruncle in here. And for the mild cases, you would use antiseptic wash, antibiotic creams. For the systemic, you would use extensive systemic antibiotics. You would use them for extensive or severe cases. For the carbuncles, you would see that this is actually very, very severe. And this would clue you into the fact that there is actually more than a single, more, yeah, so this would clue you into the fact that there is more than a single fruncle that is connected to each other, resulting in this carbuncle. So this is a carbuncle, this is a carbuncle. And the carbuncles usually present with draining pus. So you would see these areas of pus in here, draining pus, again, draining pus. All of these are characteristic of carbuncles, right? And then, as we've mentioned earlier, that you might also prevent the spread of the infection to other parts of the body using by removing the pus and the dead skin tissue. And if you remember, guys, on the first slide, we've mentioned that drainage is often approached as a modality of treatment in cutaneous disorders. You would treat with systemic antibiotics, and you would control the underlying disease. So since this is a severe type of infection, usually people who are more susceptible to diseases, so people with chronic kidney disease who are immunocompromised, people with diabetes mellitus, people with certain cutaneous diseases would get a higher chance of getting carbuncles. So you would always look into the underlying cause rather than the disease itself. So treat underlying cause before you treat the disease. For the carbuncle, extended redness, pus, swelling, and tenderness. These are all signs of inflammation. Carbuncles, numerous sites of draining pus, and usually in areas of thicker skin. And why in thicker skin? It's because you are going to have more hair follicles. More hair follicles mean more chance of actually these follicles being all infected rather than a single one, and thus presenting with the carbuncles. Okay. So this is known as cellulitis, and cellulitis is usually a disease that presents with diffuse involvement of the skin. And what do we mean by diffuse involvement of the skin? It is that you cannot actually draw a certain border that would clue you that this is actually a lesion, right? So this is diffuse involvement of the skin. You cannot draw a border that would demarcate this lesion from other parts of the skin. This is known as cellulitis. So cellulitis is an infection of the skin with some extension into the subcutaneous tissues. So what differentiates cellulitis from erysipelas, which we will later discuss, is that cellulitis tends to be more into the skin. So it's a deep tissue infection rather than cellulitis, rather than the erysipelas, which is more of a superficial one. So this is a very deep infection. Extremity is the most common, but any area of the skin could be involved as well. So it can present with both local and systemic features since it's an infection, as we've mentioned more than once. Cellulitis is in the majority of patients is caused by beta hemolytic streptococci group A, B, C, and G. And if you guys recall, A was the same one as Streptococcus pyogenes, as well as Staphylococcus aureus. The systemic symptoms, fever and chills, myalgias, and increased white blood cell count. So infection, nothing about rocket science in here, guys. So the diagnosis is clinical. The treatment is anti-strep, anti-staph, since both of these could result in cellulitis. You'd use cefazolin, nafcillin, clindamycin, vancomycin, fluoroquinolones, and macrolides, including erythromycin and azithromycin. So I think you would have to memorize these. And the duration of treatment is usually 10 to 14 days. It's a long duration of treatment, and that is primarily because cellulitis is diffusely into the subcutaneous tissue. So what is this? This is erysipelas. You would be able to draw a certain marker that would demarcate this lesion from other parts of the skin. And this is what would clue you into the fact that this is erysipelas rather than cellulitis. So erysipelas is a characteristic form of cellulitis that affects the superficial epidermis, so it's into the upper skin, producing marked swelling, right? So swelling, a sign of inflammation that usually follows infection, caused by beta hemolytic streptococci. Group C and G as well can cause it, Staph aureus, strep pneumonia, enterococci, and gram-negative bacilli. And I think those all, you would have to memorize them. So the erysipelas skin lesion has a raised border, which is sharply demarcated from the skin, as we've discussed earlier. This is the most unique feature, and it allows it to be distinguished from other types of cellulitis, which cannot be distinguished from the skin. It doesn't have a well-demarcated border. The demarcation is seen at bony prominences, and the affected skin is painful, edematous, intensely erythematous, and indurated, right? And this would present with a peau d'orange appearance. And what do we mean by that is that the skin will basically look like an orange. It will literally look like an orange. And this would clue you also into erysipelas. Induration is basically when you have the skin, and the skin, there is a lesion that would arise from the skin. This is known as induration. So the face is the most common area of involvement. It can mimic other skin conditions, so herpes zoster. And herpes zoster is basically the one that causes shingles, right? And the elderly, it can also cause the herpes zoster is the same one as the varicella zoster virus, and it would also result in the chickenpox. In a lot of you guys, I think, as children, might have been exposed to chickenpox. So herpes zoster is usually the causative agent. Contact dermatitis and urticaria, which is an allergic condition where it might be related to allergy. Actually, it might not be related to pseudoallergy, so it might arise just like that without any causative agent or any triggering agent as in allergy. So erysipelas, again, it's an infection, so you would treat it with penicillin, erythromycin, clindamycin, and fluoroquinolones, and it does have the propensity to reoccur. So it's more of, it can present as a chronic illness rather than a one-time illness. Now, this in here, in this lesion, what you might notice is that this is a lesion that would present with a black center, right? And when we say black center, apologies guys for the handwriting, but a black center would clue you clearly into the fact that this is death of tissue, right? The tissues are dying in here, just like when we have discussed last semester, I believe we've discussed the gangrene. So the gangrene was actually, I mean, when you see a limb that is undergoing gangrene, you would see the entire limb actually being black. And this would present you into the fact that the cells themselves are dying in the middle. So this is probably known as Ecthyma gangrenosum, and the name itself would clue you into the illness. So gangrenosum, gangrene, cells are dying. This is an ulcerative pyoderma of the skin caused by group A beta hemolytic streptococci. So this is a very severe form. So you would imagine that you would have group A streptococcus. This group A streptococcus might present with cellulitis. It might present with, it usually presents actually with erysipelas. And after the infection of erysipelas, someone might get the progression of the disease and would eventually get ecthyma gangrenosum, right? And this is a very severe type of illness that would eventually result in a scar. And you would eventually understand why it would result in a scar. That is because it's a gangrene. It's going diffusely into the skin, right? The cells themselves are dying. It extends into the dermis. It's often referred to as a deeper form of impetigo. Pre-existing tissue damage, right, and immunocompromised states predispose the patient's development of ecthyma, as we've mentioned before. And then the ecthyma, it would usually present with a shallow punched out ulceration. And this is because the gangrene is going diffusely into the skin. The deep dermal ulcer has a raised and indurated surrounding margin because, well, this is the necrotic area. So once you remove the necrotic area, the area that has not been infected would appear much more raised than the lesion that had been infected. The ecthyma can present can remain in a fixed in size or can progressively enlarge. So it could eventually enlarge. If a patient presents to you and tells you that, مثلا, this has begun really small and then it resulted in a large one that is, for example, 3 centimeter in diameter, this would also clue you into ecthyma gangrenosum. It could produce a scar, and we've mentioned the reason for that before, and regional lymphadenopathy is commonly seen. Why? Because this is an infection of group A streptococcus. And group A streptococcus, we've mentioned that group A streptococcus is one that would cause the strep throat, and thus you would see regional lymphadenopathy. So ecthyma, topical person ointment. So again, an antibiotic. Gentle surgical debridement because you have necrotic tissue and you would have to remove that necrotic tissue. Penicillin, clindamycin, macrolides, and cefazolin are all antibiotics that you would also use. So I think we've reached the end of lecture 1. I hope that I've explained everything thoroughly. Inshallah, I'll explain common skin disorders number 2, and then I'll explain the last one, which is the skin the skin cancer. I hope you guys understood everything. I'm really sorry that I took an entire hour just to explain 60 slides. But يعني, I hope that everything is clear. And good luck. Inshallah, you would watch common skin disorders too as well.